The vulnerable plaque hypothesis refers to us being able to identify the types of lesions inside coronary arteries that cause acute coronary syndromes, myocardial infarction, and sudden coronary death. And we've known for many years that pathologically these lesions are of a certain subtype. They're most likely called thin-capped fibroatheromas, or what we call TICFAs, but sometimes there are also lesions that are prone to erosion or sometimes large calcified nodules. Now, we're actually able to identify those lesions in patients. First of all, we have non-invasive imaging and then invasive imaging. Non-invasive imaging modalities, and particularly CT angiography, can identify lipid-rich plaques that are most likely thin-capped fibroatheromas. They're large, positively remodeled plaques with low amounts of calcium, low Hounsfield units, and those seem to place patients at risk for future events. In addition, we can use the increased signal-to-noise ratio from invasive catheter technology, having the catheter right up against the plaque, and we've done a pretty good job of being able to validate the vulnerable plaque hypothesis using radiofrequency intravascular ultrasound, or VH-IVUS. In the PROSPECT study and subsequently in several other studies, we were able to identify thin-capped fibroatheromas by VH, which then subsequently went on to have rapid lesion progression and cause acute coronary syndrome type events. We're now looking at other modalities such as optical coherence tomography and near-infrared spectroscopy to look for lipid-rich plaques or thin-capped fibroatheromas, and that will help us identify high-risk patients and plaques who can most benefit from potent systemic therapies and perhaps even one day focal or regional vulnerable plaque treatments such as bioresorbable scaffolds. What we've learned is that the development of vulnerable plaque comes from systemic inflammation, and that kind of underlies the drive for plaques to progress, which is a 20 to 50-year process. And there's a first steady progression in which plaques develop in the coronary arteries and then remodel, lay down lipid, and then suddenly transform into more severe phenotypes. And we know that plaques rupture and heal all the time. That's often a silent process. But when you get to a severe enough lesion stenosis severity or severe enough amount of plaque burden, then another plaque rupture or another thrombotic event on top of the plaque can cause either sudden death or massive myocardial infarction or unstable angina. So vulnerable plaque is a real phenomenon. We can identify plaques which prospectively, which place patients at risk for future cardiac events. And now we're really working on fine-tuning what the best modality is to identify those plaques and whether those patients should be treated primarily with systemic therapies or perhaps even focal treatments.